Thank you very much for joining us today. I'm very pleased to introduce Dr. Dana Ross, who will be talking about innovations in care for PTSD, psychoeducation as a scalable, evidence-based intervention. But before I introduce Dr. Ross, I want to acknowledge that we live, work, play, and participate in a community on the unceded, ceded, and traditional territories of 630 First Nations, each of which possess their own unique traditions and history here on this land that we now refer to as Canada. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action and the United Nations Declaration on the Rights of Indigenous Peoples. In all of our work, we're committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I myself am joining you from Toronto, which is covered by Toronto Purchase Number 13 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich the city. Many of our members also live in Vancouver, which is part of the unceded homelands of the Coast Salish peoples and the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I encourage all of you to put in the chat, if you would wish, an acknowledgement of where you are currently situated. Who are we? This is run by the Women's Health Research Cluster. We have over 750 members across 32 countries. We run a number of events, including a trainee research presentation series that there'll be an announcement soon about that. We have had some online conferences that are all on YouTube and some workshops. Please check that out on our YouTube channel. We also run some trainee travel awards, so please look out for those when we do have them for people that are presenting either sex and gender-based analysis work or work on women's health directly. We really wish to acknowledge our collaborations, people that have given us the funding to continue to do so. So please become a member and support us if you so desire. We actually have a new website. It's not up there yet. I think it's just Women's Health Research dot not sure. We'll put it in the chat for you. I don't want to give you the wrong one. So I'm going to stop sharing. And while I stop sharing, I'm going to invite Dr. Dana Ross to put up her slides. Dr. Ross is an MD, as well as she has a master's and serves as a fellow of the Royal College of Physicians and Surgeons of Canada. She serves as a psychiatrist and clinician-educator within the trauma therapy program at Women's College Hospital and is an assistant professor in the Department of Psychiatry at the University of Toronto. She's driven by a genuine passion for healthcare innovation, and she explores virtual healthcare delivery solutions and advocates for relationship-centered care approaches. She is currently leading 2 research initiatives aimed at expanding care options for individuals with complex trauma in Ontario, and a 3rd study focused on implementing virtual education and trauma-informed care for healthcare staff. Obviously, really important work. In her clinical practice, she provides trauma-focused group psychotherapy to adult survivors of adverse childhood experiences. And she continues, she's very dedicated to continuous learning and improvement, having graduated from the Education Scholars Program at U of T Center for, that's University of Toronto, just in case we have some people from outside of Canada, a faculty development and a Master Educator program offered by the Association of Academic Psychiatry. And as a First Nations physician, she finds fulfillment as a mentor to medical learners in the Diversity Mentorship Program at University of Toronto. And as many of you know, I don't like just giving all the accolades and information about people. I also like to give a fun fact. And Dr. Ross's fun fact is she likes to do acrylic painting. I would like to see some of those. And she likes to write screenplays in her spare time. I want to know if any of those screenplays are going off Broadway or on Broadway. I mean, what am I saying here? Or what do we have in Toronto that's the equivalent? King Street Theaters? I don't know why we would. But please let us know if any of your plays, hit the stage.
I will definitely let you know. So far, it's just for fun and just something that I do to do something outside of what we all do every day in our work here. Thank you for that introduction. Is there anything else that you were going to say, or should I just dive in? Okay, wonderful. Well, thank you so much for having me. I'm going to just share my screen here. Okay, so we're going to talk about innovations in care for PTSD, as we said, psychoeducation as a scalable evidence-based intervention. We're going to be looking at an intervention that we've been working on at Women's College Hospital here in Toronto called the Trauma Portal. Learning objectives. First of all, no conflicts of interest to declare. Our learning objectives are to describe the role of psychoeducation as an evidence-based intervention in PTSD care. Evaluate key features and benefits of the trauma portal and addressing barriers to access. And finally, understand how leveraging scalable, equitable solutions can improve women's health outcomes. Okay, so why psychoeducation? Why are we focusing on psychoeducation in this intervention? We know that psychoeducation in healthcare, particularly within mental health, refers to a process of providing individuals, families, groups with information, education about mental health conditions, coping strategies, available treatments. And the goal is really to empower participants with knowledge, with skills to better understand, manage, navigate challenges associated with their mental health. And the approach in psychoeducation is about things like fostering self-awareness, reducing stigma, enhancing coping mechanisms, promoting active participation in care, and many more things as well. It's a very rich intervention. Okay, so health literacy, as we know, is a key issue for women. So health literacy can empower women by giving them knowledge and tools to understand and manage their health and continue to move towards health equity and autonomy. We also want to focus on things like breaking the cycle of silence. So we know that psychoeducation can serve as a starting place for women to learn about trauma and perhaps to decrease stigma, which is particularly important in cultures or communities where mental health is taboo. And so what are some other issues around psychoeducation? Psychoeducation often involves interactive, tailored sessions, can cover topics such as symptom management, stress reduction, communication skills, relapse prevention. And here are some of the issues that we're thinking about when it comes to psychoeducation. Not a lot of providers have training in psychoeducational approaches. Certainly in my training in psychiatry, we didn't learn very much at all about psychoeducation as an intervention. Or how to deliver that to patients that we were working with. And so that I feel was an area that kind of got missed in my training personally. There's potential for high yield, low resource interventions, which is part of what drives us in the trauma portal intervention that I'll tell you more about. Step care models are often have one of the initial steps being psychoeducation, and that's all about easy access to initial lower intensity treatments. There's often lower dropout rates, particularly in trauma, and this will come up, I think, a couple times throughout the chat. But a lot of research shows with some of the evidence-based trauma interventions that there can be higher dropout rates than we might want. And so this might be a way in for some people as well. It can be delivered without needing specialty training, which is really important, particularly in low resource environments. So we're not going to talk in detail about these, but just to give you a high level overview of what does the evidence say about psychoeducation in terms of mental health. There's a lot of research going on outside of trauma in particular, looking at psychoeducation as a treatment intervention. So we've got substance use. Psychosis field is actually probably at the forefront with bipolar disorder, depression, anxiety. PTSD is starting to grow, I would say, and then bipolar. But when I look at the literature, I'm really overwhelmed by how much the psychosis field and the bipolar field, in terms of research output, has done in terms of focusing on psychoeducation as an intervention for patients, but also for families as well. And so there's a pretty strong and interesting evidence base growing there. I think the research, one of the overall points that I draw from it is that we need more research though. So there's a lot going on. It looks good, but we need more high quality research, replicated studies, and we have to decide and agree a little bit on what are the outcomes we're looking for as well. In terms of trauma, interpersonal trauma, adverse childhood experiences, it's a growing evidence-based for psychoeducation. And there certainly is stuff going on both for adult and young adult clients and starting to be more randomized control trials coming forward. So definitely this is an emerging area. Same kind of signals, looking good, but definitely need much more in terms of a strong evidence-based and rigorous studies looking at these interventions as well. Okay, so what does it, in addition to what we said, what does it say about psychoeducation and trauma care? That it is an evidence-based approach. Studies show it reduces PTSD symptoms, increases self-efficacy, and promotes engagement in follow-up treatments. So again, it's this idea, especially if someone comes from a background of having some mistrust of the healthcare system, or having had bad experiences in the healthcare system, or with mental health or with psychiatry, it can be a helpful entryway as well. Emerging role in trauma care, so establishing that safe foundation for deeper trauma work, preparing individuals for if they want to go on to evidence-based therapies like CBT or EMDR. And scalability is a huge piece and a huge interest area for me. It's accessible, psychoeducation is accessible through online platforms like the trauma portal we'll talk about. You can reach large populations without sacrificing quality because it's easier to train on, it's easier to disseminate. And if we're thinking about how can we make an impact in the healthcare field and in mental health, psychoeducation can be a really interesting option here. Okay, so let's talk a little bit about the trauma portal. So portal stands for providing online trauma therapy using an asynchronous learning platform. If any of you have had the great pleasure of coming up with an acronym for something you've been working on, it is a wild project to do. We took months to come up with this acronym. So we were trying to cram an R in there. It was interesting. But that's what we came up with, the trauma portal. And let me tell you what that is. Oops. There we go. Okay. So two main parts and then the exit interview. So the big part of the trauma portal is the online modules. So there's 8 modules that are based on our Resourced and Resilient or R&R group and the trauma therapy program at Women's College Hospital here in Toronto. That's a group that has been running there for over about almost 20 years. And it's always changing and being updated. We're always getting feedback from patients or clients and revamping as the literature comes in as well. What we did is we took that content from the R&R group, which is a PDF handout, and we turned it into these 8 multimedia modules. They're asynchronous or self-paced, so you make your way through it at your own time, at your own pace. All 8 of them are about 45-ish minutes each, give or take. And then the second part of the trauma portal is the weekly therapy group. And right now we have about 25 people in each cohort. It's optional, so about 12 to 14 people attend each week. And we made it optional on purpose. So I'm going to walk you through just kind of a broad overview of the studies that we've done. But this was something we talked about a lot as a research team and as a clinical team as well. Should this be optional or not? And why we ended up going down the optional route is we found there was a whole lot of people who really struggled to attend a weekly group at a specific day at a specific time regularly for lots of different reasons, like childcare issues, physical health issues, all kinds of different things. And so we said, let's make this intervention as widely accessible as we possibly can. And so we'll make this group optional. And then we'll ask ourselves as a team a whole lot of questions about how that went. We'll get a lot of feedback and see if that feels like the right thing moving forward. But that's where we wanted to start. So we made it optional in the studies and we've implemented it, which I'll tell you more about. And we made it optional as we implemented it in the trauma therapy program as well. The weekly group is 1 hour. It's led by 2 of our experienced trauma therapists. And it's a chance for patients who are doing the portal to ask questions about the content for that week. So it is really if it's week 3, in an ideal world, people have watched the week 3 module, then they attend the week 3 group and have some questions about the content. And we find that generally works out. If there are no kind of questions, then we've all done a million R&R groups, and so we can talk about common things that come up with the content as well. And then the third step is to attend an exit interview to provide feedback to us about how it went, review options in the trauma therapy program for next steps, and then to go on the wait list for next steps for our next group. So that's a broad overview of the trauma portal, but we'll walk through in a little bit what it looks like, and then we'll talk about some of the evidence that we've got around some of the research that we've done with it. So the trauma portal is all about some multimedia content. And what we heard and what we've gotten feedback around is people like that multimedia kind of diversity of content. So there's videos. One of the important things and one of the interesting things we heard about the videos, which were all made by all the therapists in the trauma therapy program. So every single therapist in the trauma therapy program took part in making the content, which was amazing. And one of the pieces of feedback we've heard repeatedly, and I think this is an interesting thing for people who are designing online programs, is that people actually developed a sense of connection with us as therapists through the trauma portal. So not meeting us in person, but seeing us in videos, in animations, in podcasts. They actually started to feel a connection and a sense of connectedness to us. So when they came into their following group, they actually knew us already a little bit. And I thought that was an unexpected and very sort of rich experience. We have animations, we've got podcasts, self-reflective exercises, quizzes, all kinds of little things there. Okay, so I'm going to stop sharing for a moment, then I'm going to open up the trauma portal and we're going to just look around for a minute just so you can get a real tangible kind of sense of it. One second, doesn't want to do that. Let me try that one more time. There we are. Perfect. Okay. So if you were a patient or client with us, this is what you would do. You would get enrolled in the trauma portal, you'd get an email, you'd make your own password, then you'd log into your dashboard and come into the trauma portal here. And so this is where you start. And there's a little video at the beginning, sort of explaining and welcoming everybody. And then if you drop down to the side here, you've got your handouts, packages, some general information, some additional resources around community-based resources in crisis. That's the intro. As you go through, it'll keep a pace of how much you've completed, so you can easily follow along for that. And in module 1, there's 13 pieces, as you see here, and then there's 8 modules in total. And so if you drop down, they all expand like that. But let's just look at module 1 together to get a flavor. So everything has a bit of an introduction that explains what's going to go on in the upcoming module. And we had biomedical illustrator Shelley Chen do some illustrations to bring out the theme for each of the weeks as well, which is really just cool to see her do her work and bring her creative energy to the project. We then talked about, oh, I'm gonna not play the video just because it's a bit loud. We talk really about the importance of pacing, which is a huge piece of trauma work, as we know. We talk about skill building, healing from trauma, and the kind of stages of trauma recovery approach. So some of these are audio pieces. As you'll see, everything has a transcript, or it has audio or a video, and we try to have everything have you have the ability to engage with the content in a way that works for you. So if you want to read, you can read. If you want to listen, you can listen. If you want to watch, you can watch. And so we tried to have that throughout. How trauma can show up in our daily lives, so some symptoms. Every one we have a movement break. So this is a chair sequence by my wonderful colleague Maham, who walks through a sequence of movement in order to foster sort of reconnection with body and also get people moving after watching all of this content and helping people sort of ground in the present moment. We talk about what is PTSD and complex PTSD, some hopes and concerns. There's always a skill building exercise and a reflective exercise and a commitment to trying or practicing something. So that's the general kind of gist. So you just have a sense of what I'm talking about when I'm talking about these modules. Okay. And let's go into a little bit of the research that we've done around this. We started with a needs assessment. So the long-term mental physical health implications of childhood interpersonal trauma on adult survivors is immense. However, there's a lack of available trauma-focused treatment services that are widely accessible. So that's what the problem or the gap is, the access to treatment. And is there anything here that we could do in terms of increasing access to treatment? So we were really thinking about, could we do something asynchronous? And we just had no idea whether that was an appropriate intervention or what people thought of that and if they'd be open to that. So we thought, let's start with a needs assessment and see what people sort of think about this. This study, employing a user-centered design process, aimed to evaluate the acceptability of a novel self-paced psychoed skills treatment intervention. We gathered feedback on design and development and perceptions about just the first two modules that we had built at that point of view. We really want to focus on the asynchronous format, know what people thought about that self-paced kind of piece and the technological aspects and any barriers that kind of came up around that. And one of the things that really started this whole process out was our long wait list in the trauma therapy program, which is a common problem that we hear for anyone who does any kind of trauma work. There's no shortage of need. And so what we were finding was that people would be waiting a year, sometimes even at the really dense times, like a year and a half to get into our first group, which is that resourced and resilient group I was mentioning before. And sometimes people would wait that year and a half, they'd get into the R&R. And some of the things in the R&R we do are like basic skills and strategies, like, for example, like showing people how to do deep breathing. And it was always sort of shocking and disturbing how many people would come in and and no one's ever talked to them about grounding, about basic breathing skills, about sort of basic strategies and skills that they could use. And I just thought there's no reason why people need to wait a year and a half. There's a better way that we can get this information out there. So that was the impetus to kind of start thinking about this whole thing. So the needs assessment, so the gap was the high demand for trauma services, a need for virtual interventions to improve access to treatment for PTSD and other trauma-related symptoms, the acceptability and efficacy of virtual interventions in the trauma population was not widely studied. It's starting to have a growing body of literature now, which is excellent. So our solution that we were proposing or thinking about was the trauma portal. We wanted to develop this to provide foundational trauma care more efficiently and quickly, help expand access to care while utilizing fewer therapist resources. And we'll talk a little bit more about that in a moment. So we built the first 2 of 8 modules for the study, multimedia, as we said, and then we did our focus groups. 14 participants were in the focus groups. We had 11 women identified folks, 3 men from our outpatient hospital service, completed the modules, consented to provide feedback, and we did a thematic analysis around that. This is the paper that came about as a result. And what we found were a few major themes that came forward around technology utilization, module content, thoughts about the asynchronous delivery, and opportunity for interactivity and suggestions around that. But what we noticed was participants really noted the convenience of the platform and the use of multimedia content to increase engagement. And really importantly here, they did not find the modules to be emotionally overwhelming. And that was a really important piece for us because we just didn't know going in how people would do with it. We see a wide, diverse array of people with lots of different experiences of some people have a lot of trauma work. Some people have not done any trauma work, all kinds of different experiences in life. So that was a very important piece for us. And all through our upcoming studies I'll tell you about, we also did not have people feel that there was any safety concerns or worries about becoming overly dysregulated. And I think part of that too is the way that we built the modules, really taking those breaks, dropping those skills in, dropping those movements in. And some of the feedback we got was that people really enjoyed being able to pause a video if it did feel a bit overwhelming. They could come back to it next week or never. And that gave them that choice and flexibility that I think was an important part of trauma work, trauma-informed care, and also just being able to pace. From the needs assessment, we then went on to do the open label pilot study. And so this study looked at the portal from October 2021 to February 2022. And it was a prospective single-arm study. We recruited participants from our trauma therapy program who were waitlisted for R&R. And the primary outcome for our pilot study was the protocol feasibility, looking at recruitment, adoption, intervention acceptability. And we looked at secondary outcomes as well around clinical symptoms. We did pre-post interventions looking at PTSD symptoms using the PCL5. We looked at depression, anxiety using the DAS-21, and we looked at emotion regulation using the DURS-18. In our pilot, we had a total of 66 participants enrolled in the study. 4 withdrew from the study, none withdrew due to safety concerns. And the mean age was 37 and 92% self-identified as a woman. And then you can see the breakdown of the ethnicity there as well. We found throughout our studies that we were really able to recruit people quite easily. A lot of people were curious about this, or it fit their life, rather than having to come into the hospital either for an in-person group or a virtual group that was synchronous that required them to show up at a particular time every day, every week, I should say. So some outcomes from our pilot. So the mean score on the ACE, the Adverse Childhood Experiences scale, was 5 with a standard deviation of 2.33. And 74.2% of participants had a score of at least 4. And so if you're familiar with the ACE study, goes from 0 to 10. And generally a score over 3 or 4 is considered to be a high level of trauma. 98% acceptability was very high. So with 98% reporting that the intervention increased their access to healthcare, which was great to see. 87.9 engaged with the program in some way. So either attended the groups, engaged with modules, or both. So that was also a good outcome for us. Symptom improvement we saw across all 3 symptom measures, including PCL-5, DIRS, and DAS. And 96% value the convenience of the self-paced access. They highly rank both the psychoed content and the multimedia format, as I mentioned before. So people, by and large, because I think they chose to come into the study and were fully informed and consented, of course, to come in, they knew what it was about. So we didn't come into a lot of issues around tech or access to tech, but that would be I would say, like a limitation of the study, because that's not necessarily representative of the general population that we'd like to serve. But we didn't see that in our study in particular, but probably for that reason. This is the paper that resulted from that. I think I talk about the outcomes later. Yeah, I already did. So we were really happy with that, the pilot. It went well, people tolerated it well, good feedback, good retention, all of those nice things. And so that led us to do a randomized control trial. And so the randomized double-blind, waitlist controlled parallel group trial looked to look at the effectiveness of the trauma portal in reducing PTSD symptoms and improving emotion regulation in adults with a history of ACEs. So this one we kind of knew a fair amount about the feasibility piece. We ended up asking tons of different questions in the RCT, but we really wanted our primary outcome to be like, how do people do in terms of clinical improvement when they do the trauma portal? We got really good signals in the pilot, but it wasn't powered in terms of numbers to make a definitive statement. And so that's why we went on to the randomized control trial, so that we could power it with recruiting enough people so that we could make some statistical statements, hopefully, by the end of it. So participants were randomized to the portal intervention or a wait list. They stayed on the wait list. And there was 181 people in the RCT, 91 were in the intervention, and 90 were in the wait list control. So in terms of demographics, the total, as we said, I think 183, might have to double check that number, might be 181. 2 participants withdrew from the study, though, with none withdrawing due to safety concerns. The mean age of participants was 41 and 82% self-identified as a woman. You see the breakdown there of the ethnicity or racial background. Importantly, from an RCT perspective, when we looked at the data, we found there were no differences observed in baseline characteristics between the 2 groups. So that was great. And outcomes. So as we said, the primary outcome was the change in PTSD symptoms. Specifically, we used the PCL-5, and for our primary outcome, it was very specific. So we looked at a change in PTSD symptom score using the PCL-5 from baseline to week 8. For everything else was a secondary measure, and we looked at changes in scores between the 2 groups, so the active treatment and the waitlist control. We looked at baselines, so week 1, week 8, and week 16. So after they finished the 8-week intervention, 8 weeks later, we redid all the measures to see how that would go. And that was our secondary outcomes. And then we used the same measures as before, but we added in the CAPS-5, which is a clinician-administered PTSD scale, whereas the PCL-5 is a self-report measure. So we wanted to look at both of the self-report and a clinician-administered PTSD symptom outcomes to see whether those played nice together or one of them was different than the other. And if so, we'd be very curious to know why that was. There was again a strong interest in the intervention from our trauma therapy patient group. Recruitment was 54%, retention was 54 and 74% was the retention rate. And you can see the kind of flow breakdown over here. So we had like 867 attend orientation, 623 were approached, and 342 screened for eligibility. 159 were ineligible, and 183 were enrolled. Control group, again, 90 and 91, and 2 withdrawn. And if we look at the last little bit of numbers there, 72 completed at least 75% of the modules, 81 attended exit interviews, and 10 were lost to follow-up. So we're not going to go too much into too many details today, just because I want to give you kind of an overall flavor of the research that we did from needs assessment to pilot to RCT to implementation. But I want to just highlight a few things here. So participants in the trauma portal group demonstrated significant improvements in key outcomes compared to the control group. And PTSD symptoms. So there were significant reductions in PCL scores from 8 to 16 weeks with sustained improvement at week 16. CAP scores, that's the clinician-administered PTSD scale. There was not significant difference at week 8, but there was a significant difference by week 16. So we're still kind of thinking about that. We're just writing up the paper now and going through this data. So we're trying to figure out, what's the story? How can we interpret this? What does this mean moving forward? Emotion regulation, significant improvements in the DERS-18 scores, significant increases in the self-compassion scores. And in terms of the DAS-21, there were significant reductions in the depression scores, but there's sort of 3 subscales to the DAS-21. There's depression, anxiety, and stress. No significant changes were observed for anxiety or stress subscales. So again, sitting back and just as we're writing, trying to think about what this means and how to interpret this, and if we move forward to do another study, would we change anything as a result of this, or ask different questions, or just repeat it in a different population to see? And we're still answering all those questions and discussing them. There was a high adherence to the intervention. So adherence was high, progress to next steps was successful. 72, as we said, completed 75% of the intervention modules. 75% was what we put in the RCT. So people had to complete 75% in order to move on in our program. If they didn't, they could still have an exit interview and we'd figure out what happened. And then they could either do the resource and resilient group, or we'd figure out how we could assist them. Okay, so 91% completed the exit interviews, 69 or 76% moved on to next steps in TTP. And so here, this graph, if we look at this for a moment, we just made this, so I'm hoping it is looking good. So no further trauma therapy was required. By 10, 69, as we said, moved on to next steps in the trauma therapy program, and 12 went on to redo it, but doing the resource and resilient group, either in person or synchronously in a virtual environment. And we wanted everyone to know that they could, if they went into this RCT and they just weren't enjoying the intervention, or it just wasn't for them for whatever reason, or they just couldn't get to it, it wasn't a good way to learn, that they knew they had the option at the end to do the resource and resilient group. And so they wouldn't lose out on that opportunity if they wanted to do it in that way as well. So some things that we learned about while doing this, we learned that in terms of the research studies, that communication is everything. And so as we moved from especially pilot to RCT, we kind of learned in the pilot, we had to be very clear. We had to repeat ourselves multiple times in different formats, so verbally and writing at different time points, because it's a lot, and it's a lot to come into any kind of study. You're doing all the measures, you're doing all the stuff. And we really worked on refining our communication as we went through, and I'll talk about implementing it in the trauma therapy program in a moment, and that really stands out as well. We had to invest in infrastructure, having the right, having great research staff already and a research team in place was already helpful to move forward with this. We needed to make sure, there was resources available if people didn't have a laptop or needed to borrow something, we could hopefully get that to them and talk to the hospital about that. Patient involvement early and often, right from the needs assessment and through all the feedback sources throughout the studies was really important. This is ultimately for our patients, and so we really wanted them involved right from the get-go. And we continue to have a lot of involvement and feedback as we implement as well. So I think as I do research more and this kind of implementation research, I realize it's for eternity. This will be an iterative process. So we'll always be updating, always be changing, always be improving, always being kind of questioning how we could do things better and how we could meet the needs of really diverse people as well. The other thing that's really important just in trauma-informed care and just in general in research that we're finding is offering, where possible, flexibility and choice. And sometimes that's a challenge in research because, of course, we have protocols that we're following and that are already approved, and we have to stay within that, of course. But what we try and do is ahead of that, think about, is there, for example, the 75% that people need to do of the portal, so people have room if there's something they're familiar with, or they just doesn't land for them, or they don't want to do or can't do some of the movement stuff, they can leave it and really personalize that a little bit. We also made that group optional every week, so people could choose to come to that or not. We did find people who attended the modules and attended the group felt they got the most out of it, so not too surprising. So we give people that feedback prior to going into the program to let them know that people who attend both often feel they get the most out of it. And at the same time, we say we made it optional for a reason, and we know it's not for everybody to come to a group every week. And so again, making that optional and having that flexibility. This brings us finally to the trauma therapy program at Women's College Hospital and our currently ongoing implementation study. So after having done the needs assessment, the pilot, the RCT, we were ready to implement it as part of our regular standard care in the trauma therapy program, which was very exciting. And so we did that starting in June of 2024. And so we're just starting to get enough data to get excited about what we're seeing and interpreting it. So far, we've had a 40% reduction in our wait times. So we're getting people in quicker. We're aiming and we're on track to get that down to at least 60+%. Our dream here is to get people referred to our trauma therapy program, have them in the trauma portal in 3 months. So that's what we're working towards. And so far, we think it is a realistic goal, but probably we're looking at that by summer, I would say. As opposed to the year, sometimes much longer than a year, which was 6 months ago. By the time a full year comes, so by May, we'll have 525 patients serviced in the first year, which is excellent. And that also gives us an opportunity to have a whole bunch of feedback and to really continue to refine this as we continue to implement it as well. What really makes it What's really helping us here in terms of this really significant reduction in our wait times is the lower resource use. So what that means for our resource and resilient group that we used to do, it was about 12 people, 10 to 12 people would be in a group, and there would be 2 therapists, and the group is an hour and 45 minutes every week for 8 weeks. And then there's a debrief after, and we get together about 15 minutes before. And so you're looking at about 2 hours and 15 minutes of 2 therapists' time to do one R&R over the course of that 8 weeks. Here, we've got 25 people in a cohort. Again, about half of those people end up showing up to this optional group every week. We still have 2 trauma therapists, but the weekly group is an hour long. And it has been really interesting getting feedback from our trauma therapists as well. who've there's been mixed feelings about this coming in, but people are able to do more of these portal groups because you're not going through and presenting the material like we do in our 4 Rs, where we're introducing the models, discussing them, talking through all of the psychoed pieces. Here, you're coming and you're answering questions about that come up from people who are attending about the content from the modules from that week. So it just feels like a lot less as well. That's the feedback we're getting from our therapists to come in for an hour. Not much in terms of debrief or anything like that. So just therapist time has significantly decreased. And so we can offer more of these, and it is a little bit less taxing in terms of the energy, I guess, and the mind work of walking through all of the content. The feedback, positive feedback with high acceptance, low attrition, few tech barriers, greater access to the material for patients. People really like being able to rewatch videos across mental health and of course in trauma as well. A lot of people we see have multiple comorbidities. Lots of people in trauma in general have lots of cognitive issues of various kind, but people often have depression, anxiety, lots of ADHD as well, medication, sleep issues. So lots of things that can make it really hard to show up on a weekly basis and just have to take in the material as we're talking at you. And so I think that for a lot of people, they're really finding that benefit of being able to rewatch the material. There are definitely some people who just do not want to do the trauma portal, and we do continue to offer R&R groups for people who, for whatever reason, whether it is a tech issue or they just feel quite strongly that they need an in-person or a virtual synchronous group. We do have that option as well, again, from that wanting to offer flexibility piece. But I think we're looking at like 95+% of people going through the trauma portal so far as we offer this. We weren't sure how that would go, especially looking at the literature and seeing a lot of concerns noted around tech barriers, around comfort with virtual care. But it's an interesting time because a lot of the research that we're looking at is kind of pre or early days of COVID. And so as we're in this sort of new zone of the world with this different level of comfort and different level of adoption of virtual things, I think there's a difference and a shift in general in people's comfort level with virtual care and maybe a decrease in tech barriers for some groups, not for everybody, of course. And so it's interesting. I think we're just in sort of a gray area as we go from sort of pre-COVID literature to enough post-COVID to actually get a sense of different barriers that do actually come up for different groups now as well. But tech barriers, of course, something we always want to be aware of. The goal is further decrease wait times, increase access to the portal at Women's College. We're going to hopefully be able to hire a couple more therapists, get a bunch more portals going, and really that's where we're going to also be able to really drop our wait time. And we want to, at some point, consider scaling beyond Women's College, and we're going to conduct a non-inferiority trial. I'll talk about that in a moment. Some challenges in implementation are not dissimilar from the studies. So communication, initial some confusion among staff. We ended up, coming up with some scripts and handouts and things that could be read around it. So it was really clear and took some of the stress of explaining these things off of clinicians who are already very busy and sort of doing a lot already. So we really needed to be clear on our communication rollout, which we continuously improve. Some resource limitations. So we had to really look at what's the administrative support and what are the funding constraints we're working with to put this through and really collaborate to get that going. And that's looking good. Staff buy-in, as we all know, sometimes we're more comfortable or less comfortable with change in different moments and different times. And so really wanting to talk to people about why we're doing this, what our research is showing, and getting some of that staff buy-in. I think for us, what made that particularly okay was that, as I said, every single member of our team contributed to building the multimedia content. So I think there was a sense of some ownership over the intervention to begin with. And so that's something I would just sort of recommend, if possible, is getting people really involved in that way. And then ensuring tech literacy access among users. That's an ongoing sort of project and making sure people understand what the modules are, how to get on, and walking people through that and making sure they're really supported if there's any questions about that. So we now have a designated tech support person who helps us with that, which is lovely. We know that women are disproportionately affected by trauma and that these experiences have cascading effects on mental and physical health, including things like PTSD, chronic pain, autoimmune disorders, cardiovascular risk, and much more. And we know that barriers to care, like cost and access, stigma, systemic inequities, fragmented services, really exist across the healthcare continuum. And so that's what we're hoping to look at as we think about the trauma portal and think about expanding it over the years to come, is how can we press back against some of these barriers? And we're looking at scalability, flexibility, affordability of this intervention, and offering people as much choice within it as possible. Women's health, psychoed interventions in women's health. We want to think about accessibility, tailoring content, empowerment, again, scalability to increase reach, especially those in underserviced areas, especially with lower cost interventions. And again, always that adaptability piece. And then finally, our timeline. So we're in the implementation right now. In 2025, we're going to expand access in the trauma therapy program at Women's College Hospital by increasing the number of portals that we're offering. We're going to apply for funding through CHR or other means for a non-inferiority trial in 2026. This is something I'd be very interested to hear if anyone has thoughts on as well. One of the things that we're really struggling with as we think about putting the trauma portal up against another intervention to show that it's not inferior to that intervention is, what do we use as a comparator? So one option, for example, would be, and I'm just noticing the time, I'm just going to wrap it up in a moment, so there's time for questions as well. But when we're thinking about this and really wrestling, we've been wrestling with this for like 6 months, trying to think, do we want to put the portal up against something similar, like a psychoeducation intervention? Or do we want to put the portal up against something that's an evidence-based intervention for PTSD and trauma, like cognitive processing therapy or EMDR or CBT or what have you, or exposure therapy? And so we're leaning towards going towards a evidence-based therapy so that when the trial is done, we can really say, listen, it's not worse than, but it's low resource, easier to implement, and easier to scale. And so that's sort of what we're thinking. And we're thinking maybe cognitive processing therapy in a group format. But when you start thinking about it, it actually is wildly complex because sometimes these are different lengths of time. Often it's a 12-week group in CPT in some of the literature, as opposed to our 8-week hybrid group. So it starts to get very sort of confusing about how to do the comparison. So if anyone has thoughts about that, I'd love to hear it. We'll consider adaptations as we move forward. And then eventually we'd like to think about what are the options to scale beyond Women's College in Ontario. And then, the long-term dream is, could we spread in a larger fashion nationally? So on behalf of myself and my team, I have an incredible amount of people that I work with, both on the research team and in the clinical area, and my mentors as well. So just listing them all here, they're all amazing. And this is not a one-person endeavor. This is definitely teamwork. And I love it as a result of that. So I will stop sharing and see if there are any kind of questions.
Well, first of all, thank you so much, Dr. Ross, for an excellent presentation. Please, it's a virtual, so it's always a little bit tough, but please add your little emojis if you can, because that was really great and not my area, but I understood it for the most part. And if there are any questions, please feel free to put them in the chat, or please raise your hand. I better put up the participants just in case. So I see some claps and things like that. But hopefully you did too. I do have a couple of questions. Oh, and there's also a suggestion, I think, from Romy there. Do you see it? Do you?
I see that. Or DBT. Yes, yes, good. We were thinking about DBT as well, but then we were thinking about what do you do when you have an 8-week intervention and you're going up against something that's traditionally a bit of a longer, I think, intervention in a lot of the studies. So I have to do a bit of a deeper dive to see if there's literature looking at DBT or CBT or what have you in an 8-week format. Or do we say, let's just we'll take CBT
Yeah,
as an example. Or do we say we're going to do a 12-week CPT group if that's, like, for example, the standard CPT format that's offered and compared in most literature, put it up against our 8-week hybrid thing and just say they're
yeah,
different lengths, but
yeah.
we're not going to worry about the fact that the
That gives
extra
the advantage
dosing
to
might
the
be the
yeah.
advantage. Yeah.
But maybe you'll find that they're similar, and that could be really powerful too. Is that what you're gonna say? Like, it's so what that they're, I mean, not so what, but
Yeah, we're not trying to be this one. We're not trying to be better than. We're just trying to not
yeah,
be significantly worse
yeah,
than.
yeah, exactly. Well, the success rate, the changes in scores seem pretty, um, to me were convincing. So,
Yeah.
I think that could be really great. So of course I have some questions about. Does it matter? Well, you said first of all that, of course, some people choose to do the R&R as opposed to doing the portal. About 25%, I think you said, of people coming through the program. And I'm wondering if um, is there any difference in the demographics of those individuals? Like, do more women choose the portal? I mean, that's just, broad strokes, or is it particular types of, and maybe you don't know this, but trauma, that might choose one versus the other?
Such a great question. We don't have the data yet. We've started doing more demographic collection in our program and across
Yeah.
the hospital as well. And we're doing a lot of like work on trying to think deeply about demographic
Yeah.
collection. And so that's a really there are people across the hospital thinking about this and helping us with it. So we're
Yeah.
starting to get some demographic data just in our program in general, which is actually something we haven't had a ton of in the past. And so when we have more of that, we'll be able to look back at the studies and understand that, or in the forward moving study, if we get the funding for the non-inferiority trial, we'll be able to see if there's a difference. But right now, we're not too sure.
Yeah, and then I was also thinking about how whether the intervention, and again, I'm not sure you would know this from, but you'd probably be able to get some of the data from your portal anyway, whether it differed, whether the intervention efficacy, if I can call it that, differed between, of course, I'm going to ask about men versus women, and then different forms of trauma, and whether that within each sex or within gender also different. Will you be able to, if you can't answer that question now, would you be able to get at that eventually, or is that something you're interested in?
Yeah, very interested. We can't get it because we had such a high percentage of women identified
I know. I know
participants.
that,
We
yeah.
won't be able to do any kind of breakdown there with this data, but it'd be
But you
interesting
could do
to get
within
maybe
women,
more.
maybe like within
Yeah.
women, like different types of, like what worked the best and for whom.
Right. And I think we didn't do that this time. We just looked at ACE score, and
Yeah.
so we can do a
Right.
sub-analysis in which we
Right.
haven't done yet, but we will to see if the change in scores are correlated with your ACE score in any way or not.
Yeah.
But I think in the non-inferiority, it would be very interesting to see different types of trauma, whether neglect or sexual abuse or
Right.
what have you, is
Yeah.
correlated with the intervention
Yeah. Yeah.
outcomes in any way. And I think that's really important because there's growing literature looking
Right.
at and just wondering and exploring interventions based on type of trauma. So I think that would be a very, very good question for us to ask moving forward.
Yeah, and it would be also interesting, like how are they using, even if it's all equally effective, which hopefully it is, but and it also doesn't really matter. I don't have a hope or a wish, but are there also different ways in which they use the portal itself? Like, are they faster or slower to use it? Are they the ones that opt out of the meeting? Like, I'm just wondering if those kinds of questions, because that might help better inform how to titrate it later on.
Yeah, I love it. I think these are all things that we want to look at. And as I think about like I think because I came into research later in my career. It's only been about, I'd say, 4 or 5 years of research.
We welcome you all.
And so I learned so much. I'm just in a constant state of learning here as a researcher. And so what I'm learning is just that there's infinite
So
amounts
much.
of
Yeah,
questions
there's so many
here and
questions.
like so many iterations. And so I
Mhm.
want to do all of that. And
Mhm.
I think we will think about how to pace that out over the next 4 or 5 years because I think we're interested in asking all these questions and they're important questions for sure.
Hmm. And the other thing, I don't have a necessarily a question around this, but I thought was so interesting that, and it makes a lot of sense. Um, and I can give you my glib reasons for why I thought it made a lot of sense. But first of all, I thought it was great to have all those multimedia. You got the videos, the animations, the podcasts, and then you could also learn by, watching the videos. You can read it or you can listen to it. Again, fantastic because if people have different things that are going on in their lives, they can access the information in many different formats. But you said something about the videos were really great because when people were coming into the sessions, it's all like they already knew who you were.
Yeah, yeah, I think that's one of the more actually for me, I find that the most fascinating because I think
Yeah,
there's something
yeah,
in there
yeah.
that we can learn as we do more virtual or interventions. Because I think one of the fears is,
Yes.
and what can happen is you can do some kind of virtual self-paced thing and it just feels a bit flat or
Yeah. Yeah.
impersonal or what have you.
Yeah.
And certainly that can be the case. But I think what this is telling us is that there's some way to do asynchronous
Yeah.
or self-paced interventions in a way that can still bring in a relational sort of lens. And I think what we did in there that was helpful is a lot of the interventions are two of us chatting, like
Mm.
two of the therapists, all like,
Ah,
you know,
right.
close. And so we're just at ease
Ah,
chatting and doing
yeah.
podcasts together. And
Yeah.
it was conversational, it's approachable. And I think that was a big kind of sort of piece that led to that as well. But interesting. It makes me also interested to think about like, what are the ways we could use asynchronous or virtual care adjunctively to the care we're doing? If people are able to like connect with a therapist and then there's some, grounding tools that they've recorded that they could access in between sessions or what have you. So I think there's some interesting something in there that I'm still
Yeah, I
playing
think there's
around.
a lot in there. And the sort of the glib comment I was going to make is like it's sort of, and this makes even more sense now. I think, I personally think, but it's like that idea of, well, you watch, and I'm sorry to read this, but like Netflix or something, right? So you're watching this series every night or every week, then they start to feel like family, right? And it's silly because you feel like you know these people, but you don't know them. They're playing a part. But in a way, and so the fact that you had two therapists together chatting, I think really adds to that because you get a little bit of people's personality, and I think that's really a way to reach people virtually. Um,
I think so.
that
And,
isn't.
and as as we know, lots of people have had the best experiences in their
Right,
life in the healthcare
right.
system. Different groups have really struggled as well, of course. And so another interesting way of maybe introducing people to the team and to the
Yes.
program in a way that feels maybe hopefully like a little bit
Safer.
gentle and safer and a smoother
Yeah.
entry.
And also, then they can also see there's diversity in the team as well. And
Right.
that's also really, really important.
Yeah. Very
Okay,
important.
we have like 2 minutes left, but oh, just a thank you for an amazing talk. It's always nice. Thank you very much because it's always really great to get these comments. I know from giving these virtual presentations myself, it's just nice to have nice comments out there. So thank you so much.
Thank you.
Um, yeah, what I think that you've really addressed most of the questions that I had. Although, and I hate to ask you this now at this point, but what is R&R?
R&R is the Resourced and Resilient group, the
Uh,
8-week group that the trauma portal is based
right
on.
on.
Yeah,
Okay.
yeah.
I was
Thank
like,
you.
there's something I'm missing. I don't know what it is.
That's
Um,
good though, because now I know I'll repeat that next time, make that more clear.
well,
Thank you for your comments. I do appreciate it as well. I'm seeing those. Thank you.
well, thank you again so much. If you can all join me and thanking Dr. Dana Ross again for an amazing presentation. And I learned a lot about the trauma portal and all the great work that you're doing. And thank you so much for doing the research. that you're
So
doing
thank
because
you.
it's really, really, really important. So, and I know it's extra work, but we're really happy that you're doing it. And
Thank you so much.
thank you very much.
Thank you. Bye, everyone. Thanks so much.